In today's video, we will continue with real-world settings clinical scenarios. I have 5 more clinical examples. This is the 11th video of the inpatient diabetes management course. A link to the full course is provided below. If you have already signed up for our videos PDF summary, it should be in your inbox 24 hours after the video is released on the channel. If you would like to sign up, please use the link provided below. Let's start. The patient is eating and blood sugar is stable, so ACHS is appropriate. Q4 hours or Q6 hours checks is used if the patient is NPO or on tube feeds or on TPN. One of the best practices we can do is to treat the patient based on the diet he will continue at home. So asking the patient about his diet at home would be the most appropriate next step. First of all, the patient has the right to refuse any kind of treatment, and placing him on a diabetic diet is considered a treatment. We need to fulfill his wish of having a regular diet and treat him accordingly. So I would keep him on the current regular diet. The patient is eating with no anticipation of poor or unpredictable oral intake, so there should be no issue continuing his home medications, whether metformin alone or with empagliflozin, that is in addition to a mild intensity correction sliding scale, so both options are correct. Giving 12 units only and repeating blood sugar in 4 hours is not acceptable, as this will lead to hyperglycemia for a prolonged period of time and the risk of ketosis. Checking for anion gap is not incorrect but may not be necessary given the patient is completely asymptomatic, particularly if the patient's anion gap has been normal on previous labs. Giving 20 units of regular insulin and repeated blood sugar checks in 1 hour is the best next step. I want to refer you here to an old video on how to communicate with our nurses and ask the relevant questions to extract the right clinical information. Link to that video is provided below. guess we agree that option A is still not the best next step. Option B and C are both acceptable, although I expect 20 units will produce a similar or bigger drop in blood sugar. Given the patient's blood sugar has improved, it's time to adjust the patient's insulin regimens to achieve better control and avoid critical hyperglycemia. Before making any adjustments, please review the patient's home regimen. If not available, just ask the patient or his family. Changing to a moderate intensity sliding scale also seems a reasonable option. Also at this stage, change the patient's diet to a diabetic diet may not be a bad idea. The patient's blood sugar has been poorly controlled so far, which is clearly because the patient was getting way less than his home regimen. Restarting his home regimen now will likely get his blood sugar under control. It's important to remember that on admission, I would have held metformin and cut down insulin diglodic by 50%. Now he's having adequate oral intake and encephalopathy has resolved. Restarting the full regimen is the most appropriate next step. All hospitals carry human insulins, including regular insulin and NPH insulin. They also carry one brand of long-acting insulin analogs, typically insulin glargine U100 or insulin detamir, and usually one brand of rapid-acting insulin analogs, typically either insulin lispro or insulin aspart. Here, simply just Google how to convert between different insulin brands or ask your pharmacist. In general, the dose remains the same when switching between Lantus, which is the brand name for glargine U100, Basaglar, another brand name for glargine U100, Levemir, a brand name for detamir, and Tresiba, brand name for diglodic. Back to our questions, the insulin diglodic / glargine ratio conversion ratio is 1:1. The patient has already received 10 units so far, so I will add 35 units and resume the home dose the next night. On the side, let's assume that I was extremely busy when the nurse called me with that critically elevated blood sugar. A trick you could do is to order a Q1 to 2 hours moderate to high intensity correction sliding scale ×4. A Q1 hour may be difficult to do on the floor, so Q2 hours correction sliding scale can be used. This way the nurse will check blood sugar every 2 hours and provide coverage based on the scale. This will buy you time for the next 4 to 6 hours, but make sure, don't forget about patient. Make sure to follow up on the patient and assess his diabetes regimen. Before making any changes, it is wise to review the trend of his blood sugar since admission to see if this is relatively low blood sugar is just a sporadic value or if it has been a consistently low value in the morning. let's start with morning hypoglycemia. Before making any adjustments, adding a bedtime snack and making sure the patient eats it likely will take care of that. I recommend adding bedtime snacks to all patients with controlled diabetes or those with low morning blood sugar. I refer you here to my first video in the series, Home versus Hospital Diabetes Management. Let's set some general guidelines here. If the hyperglycemia patterns happen at the blood sugar check before breakfast, increase the bedtime long-acting insulin dose by 10%. If the hyperglycemia pattern happens at the blood sugar check before lunch, increase the breakfast rapid-acting insulin dose by 10%. If the hyperglycemia patterns happen at the blood sugar check 2 to 3 hours after lunch, increases the lunch rapid-acting insulin dose by 10%. If the hyperglycemia patterns happens at the blood sugar check 2 to 3 hours after supper, before bedtime or right at bedtime, increase the supper rapid-acting insulin dose by 10%. Now for hypoglycemia patterns, we simply decrease it by 10% instead of increase it as in hyperglycemia. Back to our patients. If morning hypoglycemia persists despite bedtime snacks, we cut down insulin detemer evening dose by 10%, which means cutting down evening detemer to 13 units. For the before lunch hyperglycemia, simply we increase before breakfast insulin lispro by 10%, the new dose will roughly be around 6 units. The same applies for pre-dinner hyperglycemia. We increase the before lunch insulin lispro by 10%, which again will be roughly around 6 units. Also make sure the patient is on a diabetic diet. One last thing, if the blood sugar remains persistently high despite multiple adjustments and despite the patient is on a diabetic diet, check if your patient is sneaking any candies or ice cream or if someone bringing them food from outside. The patient has poorly controlled diabetes here. He is non-compliant at home and he wants to be on a regular diet. Starting basal/bolus insulin therapy plus insulin slide scale would be a better option to quickly get his blood sugar under control. Resuming his home metformin, which he likely was not taking, plus insulin slide scale is not completely a bad option, but likely will be inadequate at this stage. For those who are on non-insulin therapy, the starting basal insulin daily dose typically ranges between 0.2 to 0.3 units per kg. And for prandial insulin, 0.05 to 0.1 units per kg. So both 16 and 24 units of basal insulin seems appropriate. The same applies to the 5 units and 8 units of the scheduled premeal insulin. Whenever we make an adjustment to an insulin regimen, we need to give it time, usually 1 to 2 days before considering any adjustments. Options A or B are not incorrect, but option D is also very reasonable in this particular case, given his history of IV drug use and non-compliance. The patient is close to being discharged, and thinking ahead for the best home regimen, oral generic medications are cheaper and safer in his case, and starting them while inpatient and on a regular diet, which he will be doing at home, will give us an idea about his blood sugar control when he gets home. Now, this is a general things for you. In general, the goal of any hospitalization is to treat the acute sickness and stabilize patients to a point where he or she can finish the treatment plan as an outpatient. Chronic issues can be managed outpatient. In our case here, the patient's arm cellulitis is resolving. Poor diabetes control is an issue that can be managed as an outpatient. Blood sugar values are high, but not high enough to the point we need to cancel his discharge. We mentioned in the DKA video that the presence of anion gap and ketonemia are essential to diagnose DKA. The patient here has a markedly increased anion gap, so reviewing urinalysis to look for ketones and ordering serum ketones seems reasonable. The patient is acutely sick with increased anion gap, acidosis, and hyperglycemia, and if she is not in DKA yet, she will be soon. Initiating the DKA protocol is the best next step for this patient along with infection treatment. Of course, no insulin yet. Initial potassium was 3 and we are not sure if the insulin pump was on or off. So we start the potassium supplement as soon as the blood is drawn. If your facility has what we call the iStat or point of care analyzer, which gives you the result in less than 5 minutes, then you can wait for the results before you give potassium. The patient blood sugar is right around 250, which is the cutoff where we add dextrose to the IV fluid. So the initial bolus can be skipped and start the drip right away at 0.1 per kg per hour. Two things here, blood sugar drops below 250 and the corrected sodium is 140 and anion gap remain elevated, which means we need to add dextrose solution. Change the fluid to 0.45 ns and decrease the drip to 0.02 to 0.05 per kg unit per kg per hour. Remember, in DKA we monitor the anion gap, not the bicarb level. Patients at this point has a non-anion gap metabolic acidosis, which is likely from saline administration. It's appropriate to start the transition at this point. So we simply ask the patient to switch on her pump basal infusion rate only, then switch off the insulin drip 2 hours later. Once the insulin drip is off, we ask them to DC IV fluid, and if IV fluid is still required for any reason, take off the dextrose element. Please start the patient on a diabetic diet. Ask the patient to restart her home pre-meal carb count insulin coverage based on her insulin to carb count ratio, plus ask her to start the correction insulin amount based on the patient's insulin correction factor. This is something I explained in the last video. In the end, if you like this video, please give us a thumbs up and share it with your colleagues. Thanks for watching and see you soon.